People, welcome to Doctor Academia. Today we are going to discuss a topic which is very familiar to you guys, and that is none other than tuberculosis. So, tuberculosis are the name which is very familiar to you guys when you're a medical student or if you're a doctor. You'll be in so many of these cases in your hospitals, and let's discuss some characteristics of this disease, the bacteria that is causing them, and how does it work. So, tuberculosis, as the name says, it is caused by Mycobacterium tuberculosis, which is an acid-fast bacteria. So, this acid-fast bacteria itself, what does it consist of? It consists of mycocytes, mycolic acid, arabinogalactan, peptidoglycan layer, and a cell membrane. So, this mycolic acid is responsible for the staining, the resistance, the pharmacology, and everything. So you'll be seeing patients and they will come to you telling the history of they have cough and this fever and weight loss and everything. So how does a patient with a TB or how does a patient gets a TB? So when a patient, let's say if a patient has TB and he coughs and what comes out of his mouth, the sputum comes out. So the sputum comes out of his mouth or the droplets comes out of his mouth and it infects people who are at a certain risk. So it can infect all age groups. There's no exception. It can infect everyone. And considerably, it is said to have infect males more than females. And people who are living poor quality life, poor housing, overcrowding, undernutrition, or lack of education. Lack of education means if the patient should have like a minimum knowledge about how this TB gets infected, TB is getting infected, and how we should avoid or how we should restrict a patient of TB getting running around. Then compromised immunity. That means if the patient has HIV, CKD, diabetes, etc., are at a very high risk of getting pulmonary tuberculosis, which is most common form of tuberculosis that we see in our daily base OPDs or hospitals. So how does it infect actually? So if it is sputum or if it is a droplet nuclei, it should have a minimum concentration of 10 raised to 4 bacilli per ml. And these get inhaled into our body and get adhered into the macrophages. So as macrophages, they like to eat something. So these bacilli get phagocytosed. But there are two situations there. One, if they survive, they can cause a full-blown TB. If they and if when get after getting phagocytosed, if they stimulates the T helper 2 cells, there will be a sudden release of interleukin 2 or interferon gamma. And interferon gamma or interleukin 2 can activate macrophages to their fullest potential. And these active macrophages destroy the bacteria and we do not get the disease. So pulmonary TB, which is the most common form of TB that we see every day. So there are two types of pulmonary TB actually, primary pulmonary TB and post-primary or secondary pulmonary TB. So what does it mean? If it's a primary pulmonary TB, that means it is initial infection. That means patient has not been exposed to any kind of TB infection previously, and this is a new episode for him. Mostly it affects children, and where does it affect? It affects the lower part of the upper lobe or the upper part of the lower lobe of the lungs, and the infected foci is called Ghon's focus. If the Ghon focus along with the lymph nodes get affected, it's called a primary complex. And about the post-primary or secondary primary TB, it actually denotes a reinfection or a reactivation, which mainly affects the adults. There are cases where we see adults who getting infected again and again and again, which comes under the category of primary, post-primary or secondary pulmonary TB, which usually affect apical and posterior segment of the upper lobe. Why is that? Because the apical segment of the lobe has the most ventilation. That's why these bacteria gets attached to there. There is like a ventilation perfusion ratio that you study in physiology, and perfusion at the apical lobes is less because of the presence of gravity, and ventilation is very much high. So since ventilation is very high, this TB has a very uh, high chance of getting infected to the upper lobe. And the focus or the infection or the calcified infection here, it is called as Asman or Simon focus. So once the patient comes to OPD and we suspect that the patient has TB, we try to diagnose it. So how do we diagnose a patient, like using lab examinations? So a patient is coming to me and he's saying that he has features, he has complaint of cough since 1 month, and he has recurrent fever since 1 month, and he has weight loss. So I'll suggest him to do a sputum examination. Sputum examination, we do a spot sample and an early morning sample. And we can't directly take the sputum sample for any examination. We need to decontaminate it and digest it. For that, we use either 4% NaOH or N-acetate cysteine with 2% NaOH. After doing this process, it will be it is used for detecting the acid-fast bacilli. Now, the most common staining is an staining that we used for staining the Mycobacterium tuberculosis. So I have written a mnemonic. Class has asked mnemonic. C means carbon fusion. H is heat. A is acid, that is sulfuric acid 25%, and M is methylene blue. These are done in order to stain as Mycobacterium tuberculosis or an acid-fast bacilli, and the concentration of the acid is 25%. There's another staining called quinone cold staining, where we will not be using any kind of heat, but we will be adjusting the phenol concentration inside the carbon fusion to get it stained. Now the culture medias, what kind of medias are used? We can use solid media or we can use liquid media. What all solid medias are we using? We can use LJ medium, Levinson Jensen medium, which is very important. And what kind of colonies they are showing? It can show rough, tough and buff colonies. So smooth colonies in LJ medium are seen in Mycobacterium bovis. And Tarshish medium, which is a blood-based medium. I think this was asked in neetpg a long time back. Low effort serum slope, Middleburg 7H11 and 7H10. Liquid medium, which include Middleburg 7H9, Dubos, Posca medium. And one other thing is that automated cultures. Automated cultures just mean that it includes liquid culture with enrichment growth medium or an antibiotic mixture. You must have seen in your microbiology textbook that like Bactec MGIT, Bactec 460 and all. So what does Bactec MGIT means? MGIT means Mycobacteria Growth Indicator 2. That means It uses some kind of indicator to know that mycobacteria is growing inside. Here we use O2 sensitive fluorescent compound dissolved in the broth. So when the mycobacteria consume the oxygen, so the mycobacteria require the oxygen to grow, and now there's no more oxygen detected inside the medium. It allows the fluorescence to be detected. That means microorganisms need to consume the oxygen to grow. Only then the fluorescence will be detected. Then there's backed alert or back tech for 60 and all. So how do you differentiate between mycobacteria and other organisms inside the mycobacterium tuberculosis complexes? So mycobacterium tuberculosis is niacin positive, nitrate reduction positive, pyrrosin amidase positive, then also catalase positive. Catalase is positive in mycobacterium TB and mycobacterium. So how do you diagnose a case of latent TB? You must have seen kids coming with complaints of cough and everything, and we have a suspicion that their child has TB or not, or if the person has TB or not. So we need to detect it. So there's a test called tuberculin test or Mantoux test, which is actually a type 4 hypersensitivity reaction. That it means it is a delayed reaction. So we inject the patient with 0.1 ml or 1 tuberculin unit of PPD, purified protein derivative antigen, which injected intradermally or the flux over the forearm. Since it is a delayed reaction, after 40 to 72 hours, we see the reaction. If it is more than or equal to 10 millimeter, it is positive. If that intervention is more than or equal to 10 millimeter, it is positive. So there are cases that which can show false positive. That means if he is on BCG vaccination or if it is infected with a non-tuberculosis mycobacterium. False negative include advanced TB, miliary TB or decreased immunity. Miliary TB is disseminated TB which is spread in blood. So there's also a test called interferon gamma release assay or IGRA, which is a highly specific test. And this specific test actually uses some specific antigens like the CFP10 or ESAT6. So how does it work? So we collect some sensitized T lymphocytes from the person who is having or who is suspected having TB, and we expose it to the ESAT or the CF10 antigens. And upon getting exposed by this, there will be a sudden release of interferon gamma, and thus we detect mycobacterium TB. So this topic which I have discussed here actually contains just the introduction, pathophysiology and the lab diagnosis of how detecting the mycobacterium TB. So hope you guys understood it. Thank you.